Greetings to all of you, my dear students. Today we are going to discuss something about anti-epileptic drugs. Because this is a very vast topic, I have divided the entire topic into four small sessions, I can say. So number one will be on introduction to anti-epileptic drugs, and number two will be on conventional anti-epileptic drugs, and number three will be on newer or novel anti-epileptic drugs, and number four will be on prescribing guidelines along with the management or pharmacotherapy of various sorts of epilepsies. So now let us see what is about introduction to anti-epileptic drugs. So I'm going to cover this topic under the following subheadings, that is introduction, neuron pathophysiology, types of epilepsy, anti-epileptic drugs, pharmacokinetics, and mechanism of action of anti-epileptic drugs. Epilepsy is a common neurological abnormality affecting about 1% of the world population. And globally, it is the fourth most common neurological disorder after migraines, cardiovascular disease, and Alzheimer's disease. It usually presents in childhood or adolescence, but may occur for the first time at any age. So immaterial of the age. So you may be able to see the epileptic attacks occurring in either newborns or even early school age children, or even adolescents, or even senior age group also. So let us see what is the difference between the terminology, that is seizure and epilepsy. Seizure means it is a sudden and transient episode associated with abnormal excessive electrical discharge from a group of CNS neuron. It is a single episode. Okay, seizure. Single episode associated with abnormal excessive electrical discharge from a group of CNS neurons. Then epilepsy means a condition characterized by recurrent episodes of such seizures. That means multiple seizures occurring recurrently or repeatedly together. So that is epilepsy. So that means a patient should not be described as having epilepsy until a few episodes of non-febrile seizures have appeared. That means children, in case of children, whenever there is fever or rise in temperature, then there is a possibility of seizure attacks in some children. So we can't diagnose it as epilepsy. When there is no fever and then seizure attacks are happening again and again, then only we have to consider it as epilepsy. So seizure is a single occurrence of jerky movements and other features of a fit. Does not need any treatment with the anti-epileptic drugs or even surgery. We need to wait for more than 3 such attacks occurring repeatedly, so that then we can think about the pharmacotherapy of that particular epilepsy. And epilepsy is defined as 2 or more than 2 unprovoked. Unprovoked means there is no fever, something like that, no other reasons are there. So 2 unprovoked seizures occurring in an individual. So anti-epileptic drugs are used, and non-responding or resistant patients, they may need even surgical management also. So epilepsy is a collective term for a group of chronic CNS disorders characterized by paroxysmal cerebral dysarrhythmia or recurrent seizures associated with brief episodes or seizures of disturbance of consciousness. So the patient may lose the consciousness or may not lose the consciousness also. It depends on the type of epilepsy that the patient is suffering from. And with or without a characteristic body movement, that is like convulsion, fit kind of thing. Convulsion may be present or may not be present. That we'll discuss about when we come to the types of epilepsy. And sometimes even autonomic hyperactivity, like a rise in blood pressure, rise in pulse rate, all these things will happen. Then J.H. Jackson, British neurologist in 1863, discovered epileptic convulsions, otherwise known as Jacksonian epilepsy. So here you can see this is the normal activity. Neuronal fibers discharging the neuronal discharge of the action potentials occurring at regular intervals of time. And here the neuronal discharge is too rapid, all of a sudden, and together multiple or recurrent. This is abnormal activity. Okay. The rapid, rhythmic, and synchronous firing may occur due to sometimes even epilepsy, and also Other disorders which can lead to epileptic disorders like that of it is similar kind of epilepsy. It is not epilepsy, like systemic disorders, which can be hypoglycemia or hypocalcemia, and intracranial or severe systemic infection, and even electric shock, overdose, or toxicity of certain drugs. Those are otherwise referred to as proconvulsant drugs or epileptogenic drugs, and then unprovoked without any exogenous cause, that is idiopathic. If seizures or convulsions are unprovoked without any further reason, then it is called as epilepsy. The site of origin of discharge is called epileptic focus, from the area from where the epilepsies are arising. From here, the discharge spreads to the surrounding areas of the brain. So from that focus, it will be spreading throughout the brain. The site of origin of abnormal neuronal firing determines the symptoms that occur. So which part of the brain is involved, from where that focus is originating, depends upon that leads to the particular characterization of symptoms of that particular epilepsy. For example, if the motor cortex is involved, then you can see the generalized convulsions. And if there is the focus within the parietal or occipital lobe, you can see visual, auditory, and olfactory hallucinations. And the causes of epilepsy are, it could be like genetic influence or head trauma, brain conditions like any infection, something like that, and infectious diseases and prenatal injury and even developmental disorders. The risk factors could be any age and family history, stroke and other vascular diseases, and dementia, and even seizures in childhood, then further evolving into adolescent epilepsy. The neuro and pathophysiology. Coming to the neurophysiology, depending on the neurotransmitter release, the brain neurons are grouped as excitatory and inhibitory neurons. This point we have discussed already in the introduction to CNS. GABA is an inhibitory transmitter acting through GABA receptors, whereas glutamate is an excitatory transmitter acting through NMDA and non-NMDA receptors. So here you can see this is the normal brain, whereas this excitation because of the glutamate and aspartate neurotransmitters, and the inhibition because of the inhibitory neurotransmitter, that is GABA, is in balance. So this is normal. Whereas here in epileptic brain, there will be excitation, exaggerated excitation, because of the exaggerated release of glutamate and aspartate, and inhibition of the inhibitory neurotransmitter, that is GABA. So this results in the development of epilepsy. So the activation of these receptors modifies various voltage-gated sodium, potassium, calcium, and chloride ion channels, and excites or inhibits the neuron. Excitatory neurotransmitters are involved in the initiation and spread of the seizure discharge, and the inhibitory neurotransmitter, that is GABA, is responsible for its termination. So this also, I think, we have discussed in the introduction to CNS. So here you can see epilepsy, exaggerated excitation, and inhibition of inhibitory forces. So here, when we want to balance this through anticonvulsants, we need to reduce this excitation or control this excitation through voltage-gated sodium channels, calcium channels inhibition, and then inhibition of glutamatergic excitation. And inhibition, this inhibitory pathway has to be stimulated. That is, GABAergic transmission has to be stimulated. Then coming to the pathophysiology, so we have two terms here. That is, one is hyperexcitability and another is hypersynchrony. Let us see what is this. Hyperexcitability is the abnormal responsiveness of the neurons to an excitatory input leading to multiple discharges. Abnormal response of the neurons is hyperexcitability. Whereas hypersynchrony refers to the recruitment of a large number of nearby neurons to an abnormal firing mode. So suppose the focus is there, focus got stimulated, and one neuron fiber is getting stimulated and then discharging the neuronal action potential. And not only that, it will stimulate the surrounding neuronal fibers also, and so that they will also come and join, and together neuronal network of fibers together they start discharging the action potential. So together They fire synchronously, that is hypersynchrony. So hyperexcitability, that is abnormal responsiveness of the neurons, and then hypersynchrony. Both together can give rise to a seizure manifestation. So normally, the brain contains billions of neurons which fire asynchronously. That means one neuronal fiber, that is nerve fiber, may be stimulated. So it does not mean that the other nerve fiber also will get stimulated at the same time for the same period of time. Okay. So that is asynchronal discharge. What is the reason for this? Inhibitory feedback loops in the normal brain. They regulate the frequency of firing of individual neurons and prevent synchronization. This happens in the normal brain. When such inhibitory feedback is defective, a large number of cells in a given area of the brain fire at the same time. That is, they synchronize. So many nerve fibers, they synchronize, and then together they start getting stimulated, producing self-regenerating electrical impulse. So firing together, such an area constitutes an epileptic focus. Okay. So paroxysmal discharges in cortical neurons, a seizure originating from gray matter of any cortical or subcortical area, subnormal firing of neurons, then breakdown of normal conductance, membrane conductance, and inhibitory synaptic currents. So if it is locally, then it can be called as focal seizures. If it is spreading throughout the brain and evolving, giving rise to the manifestations of seizures in all parts of the body, then it may be named as generalized seizure. So seizure producing stimuli, that is trauma, high fever, brain injury. So a small group of abnormal neurons undergo prolonged depolarizations associated with the rapid firing of repeated action potentials. So these abnormally discharging epileptic neurons recruit, they also make the other adjacent neurons join together with them, which they are connected into the process of seizure manifestation. So the electrical discharges of a large number of cells become abnormally linked together, giving rise to a storm of electrical activity in the brain. So seizures may spread to involve adjacent areas of the brain or to establish anatomic pathways to other distant areas. So you can see if it is focal partial phase and getting manifested into later on generalized phase because of the inhibitory feedback loops, control is lost. Then types of epilepsy. Somebody was asked me regarding this when I was discussing about the anti-epileptic drugs class. So they were asking me to discuss something about in detail about the types of epilepsy also, so that it will be useful for their final MBBS also. So I have added these slides also in this session. So types of epilepsy. Seizures can be divided into two broad groups, that is generalized seizures and focal seizures. So here you can see focal seizures means focus is limited to a particular part of the brain. Generalized seizures means this focus is getting spread to different parts of the brain. So that is generalized. Number one is generalized. We'll discuss one by one now in detail. It is previously known as grand mal epilepsy. Mal means illness. Grand means it is a major illness. So generalized seizures may begin either locally and then progress to include abnormal electrical discharges throughout both hemispheres of the brain with bilateral EEG abnormalities. So patient usually has an immediate loss of consciousness. Remember, this loss of consciousness may be present in some sort of epilepsies and may not be present in some sort of epilepsies. So based on that, you will be able to diagnose the type of epilepsy along with the other manifestations that the patient exhibits. Okay. So here in generalized epilepsy, there is an immediate loss of consciousness. So this generalized seizures can be categorized into various subtypes again. Number one is that is like tonic-clonic seizures or grand mal epilepsy. And then absent seizures, otherwise known as petit mal epilepsy. Petit means tiny, small illness that is like occurring for a very short period of time. Grand mal means major illness occurring for a long period of time. So this petit mal epilepsy is again subdivided into typical and atypical. then tonic seizures, clonic seizures, atonic seizures, myoclonic seizures, and infantile spasms. Then this is like what we have discussed earlier. This is generalized seizures, all these put together. Then comes focal seizures or partial onset seizures, which begin in a local cortical site. Then third one is focal, generalized or unclear epileptic spasms, otherwise known as unclassified seizures. So focal seizures, generalized seizures, and unclassified seizures. So the drugs used for all focal seizures are generally the same, whereas in the case of generalized seizures, they depend upon the type of seizure in different subgroups. Okay. The nomenclature developed by the International League Against Epilepsy, there's like all group of countries together, they have standardized the types of epilepsy and the classification for seizures and epileptic syndromes. That is International League Against Epilepsy. So coming to the next classification, this is, we have discussed already generalized seizures subtypes, and then partial or focal seizures, again subdivided into simple partial seizures, complex partial seizures, and partial seizures getting evolved into secondarily generalizing. Simple partial seizures, there is no loss of consciousness, whereas in complex partial seizures, there is a possibility of loss of consciousness. So now we'll discuss, this is the broad classification. Now we'll get into the details of each and every type of epilepsy. Grand mal epilepsy or grand mal seizures or tonic-clonic seizures. So this epilepsy is associated with an ARA prior to seizures. ARA means the patient may be having like a signal indication that the patient is going to land upon in an epileptic attack. It may be like visual, auditory, or olfactory, whatever it may be. We'll be discussing all this over a period of time. You will come to know. So the patient falls to the ground in stiff tonic phase. The legs will be extended and then the legs will become stiff with an epileptic cry. Epileptic cry that is caused by tonic contraction of laryngeal muscles. What happens when the muscles become stiff? The chest muscles also become stiff and they'll get contracted, because of which the air that is present in the lungs will be all of a sudden forcibly expirated through the tracheal pathway. That will give rise to a sound which is known as epileptic cry. And this is followed by clonic convulsions, that is repetitive bilateral muscle jerking. This is convulsions or muscle jerking. And then to coma. So the patient may lose the consciousness, which may last for about 15 to 30 minutes. So first one is ARA, then tonic phase stiffening, and then clonic phase conversions. So all this will be occurring for a period of 15 to 30 minutes. That's why there is known as tonic-clonic seizures. Both the phases are present here. And then recovery is associated with stupor, amnesia, mental confusion, and post-ictal or post-seizure depression. Ictal means seizure. So after the seizure, the patient may land upon in all these sorts of manifestations like amnesia, mental confusion, depression. The patient may even have the incontinence, headache, exhaustion due to depletion of glucose in the energy stores, drowsiness, and sleep. So all these manifestations are together considered as post-ictal period symptoms. Okay. Then the attack may be accompanied by tongue biting because of the clonic manifestations. The patient may bite his own tongue, and then frothing may be there through the mouth, and then incontinence may be there. And in some cases, there is no recovery of consciousness in between the attacks. Suddenly, this tonic convulsions, tonic epilepsy, tonic seizures, and then clonic seizures, and then they'll stop for some time. And then again tonic, and then again clonic. But in certain cases, this tonic-clonic seizures, the time period, there will not be any gap between two attacks, two episodes, I can say. So no recovery of consciousness. The patient will be losing the consciousness and this tonic-clonic conversions will be there. Okay, so no recovery of consciousness in between. So that is known as status epilepticus, which is a clinical emergency. Here you can see tonic phase, generalized, stiffening of body and limbs, back arch like this, the patient will be like this, and then cyanosis, incontinence, epileptic cry, you can see in the patient. And clonic phase, this is like clonic jerks of limbs, body and head, different parts of the body. Then salivary frothing and cyanosis, and eyes even blink repeatedly together. Then this is post-ictal confusional stage. There the patient will be just losing the consciousness, and he's not aware of what has happened also sometimes. And then this is majorly associated with depression and fatigue also. So that is grand mal epilepsy or generalized seizures. Now coming to the petit mal epilepsy or absence seizures. These are the main seizure types in 15 to 20% of epileptic children. These children may experience absence seizures 100 times per day, and about 60 to 70% of such patients will have spontaneous remission during adolescence. Again, getting back again. And they are responsive to pharmacotherapy like that of the grand mal seizures. But the difference between grand mal seizures and absence seizures is there is no aura. So the attack appears without any warning signal, and there is no loss of consciousness. And the seizure typically lasts for just few seconds. There it was 15 to 30 minutes. So if there is a lapse of consciousness, it is hardly for just 5 seconds with any loss of postural control. And there is no post-ictal confusion or even amnesia. So everything is no here, absence, but seizures. Okay. These are characterized by subtle bilateral motor symptoms such as rapid blinking of eyelids. So the patient will be like blinking the eyelids fast, fast, fast like this. Then chewing movements or small amplitude clonic jerks of the hands for a few seconds. That is petit mal epilepsy. You can see between seizures he is normal. There is no loss of consciousness. And during seizures, vacant state, he will just be sitting like this. And if you speak to him, the patient will not respond to your verbal commands. And he is not aware of what is happening during that period. Eyes will be rolling upward, and there is lack of response. So this is typical absence seizures. What is atypical absence seizures? We have discussed that typical and atypical types are there regarding absence seizures. Atypical absence seizures means it is slower onset and longer duration, and it is less responsive to pharmacotherapy, unlike that of the typical absence seizures. And it is most commonly associated with mental retardation. Okay. Then akinetic or atonic seizures, also known as dropout attacks. So there is sudden loss of postural tones. The patient will be like standing or in sitting posture, and all of a sudden he will tilt to the head, will be sagging to one side, and then patient will be falling down. Okay. Without accompanying any tonic movements or clonic. The patient will just be sagging down and then just falling down. Head may sag to one side, or the patient may fall all of a sudden. Consciousness may be impaired, but for a very brief period of time, but there is no post-ictal confusion. And this akinetic or atonic seizures or dropout attacks is mainly reflect diffuse brain damage, and it is just a manifestation of secondary generalized epilepsy. You can see the patient from the standing position falling down, so sagging down, I can say, falling down with head to one side. Then tonic seizures. These are characterized by rigid, violent muscular contractions with stiff and fixed extended legs. Okay. Then this is only tonic moments will be there. That is tonic seizures, less than 60 seconds long. Clonic seizures. Seizures consist of shorter episodes of muscle contractions, repetitive muscle cells that may closely resemble myoclonic jerks. There is a difference between these two. Consciousness is more impaired in case of clonic seizures when compared to the myoclonic seizures. That is the main difference between these two. Myoclonic seizures, it is like very short period of time, very brief, that is less than 100 milliseconds. Involuntary skeletal muscle contractions that may involve either one part of the body or entire body without loss of consciousness again. And most commonly, the patient complains of sudden jerky movements appearing during sleeping that may recur for several minutes. So that could be because of myoclonic seizures. They occur at any age, but usually around puberty or LD adulthood, they start appearing. This is less regularly repetitive and less sustained than clonus. you can see. So then like myoclonic, muscles are becoming stiff and then repetitive stiffness and jerky movements for very short period of time. That is myoclonic seizures. Jerking of arms, shoulder, and head, you can see. Okay. So episodes typically occurring soon after awakening. So we have completed this, all these types of varieties of generalized seizures. Now we will get into the classification of partial seizures. That is simple partial, complex partial, or partial seizures secondarily generalizing. The partial seizures. These are the most common seizure types occurring in approximately 80% of epileptic patients. Originate in a localized area of the brain that is most commonly medial temporal lobe or inferior frontal lobe, with a localized focus of each abnormality and may or may not become generalized even. So it may be partial, not evolving into generalized type also sometimes. So manifestations depend on the brain region or regions involved. Patients may lose consciousness, and this may begin with motor or non-motor activity. So focal origin may be evident clinically or may be even detected in the EEG based on the clinical manifestations or investigations also. In adults specifically, the commonest form of epilepsy is focal epilepsy. Most of the cases we see focal epilepsy only, but in the commonest associated lesion is in hippocampal sclerosis. And it is again divided into three subtypes. Number one is simple partial seizures, otherwise known as Jacksonian seizures. It is named after the scientist that we have discussed in the introductory slide. So these Jacksonian seizures are again subdivided into Jacksonian motor seizures and Jacksonian sensory seizures. So Jacksonian motor seizures means there is unilateral clonic movements. Motor involvement will be there. Clonic movements that begin in one group of muscles and spread gradually to adjacent group, reflecting the march of epileptic activity like mouth, then thumb, great toe. So different parts will be involving. So that is motor involvement, so known as Jacksonian motor seizures. Whereas in Jacksonian sensory seizures, the patient may have somatosensory symptoms like auditory hallucinations. So he will hear something which is not there. Visual hallucinations, he will see something which is not there. Olfactory hallucinations, he will smell something which is not there. And at times, sometimes the patient may experience like pins and needle pricking sensations also. Is a lot, all these symptoms will be manifesting together. So all these sensory manifestations are predominant. So that is known as Jacksonian sensory epilepsy, sensory seizures. So there is no loss of consciousness in simple partial seizures. So you can see motor involvement, tonic-clonic moments, and grimacing, and then autonomic activity like sweating, flushing, pallor, all these things will be there in the patient. And somatosensory, that is like visual, sees flashes of light, and then scotomas you can see, and unilateral or bilateral blurring of vision will be there. And auditory hears ringing sound or hissing noises, something which is not actually existing. It is like hallucinations. Okay. Then complex partial seizures or temporal lobe epilepsy or even psychomotor epilepsy. They originate in either temporal or frontal lobe, characterized by partial loss of consciousness. Okay. Whereas in the earlier case, there was no loss of consciousness, here partial loss of consciousness. It is a dreamy state of psychic seizures where the patient behaves as partially conscious with automatism. He may get up, put on his clothes, and then start walking or even driving the car. But if you talk to him, he will not respond to your verbal commands. That is complex partial seizures. And he can't even recollect the events that he has put the clothes, he was walking and he was driving the vehicle. All these things he cannot remember also after the attack is over. So the attack is usually associated with auditory, visual, or olfactory aura. Sometimes the patient shows other types of automatism like lip smacking, fumbling, and then scratching. All these things the patient will not be aware of. Without his knowledge, he will be doing that. It's like repetitive automatisms, I can say. So here you can say motor involvement will be there. and then impairment of consciousness, cognitive and affective symptoms, and psychomotor phenomena like chewing, movements, gritting, and lips. Uh, it's like lip movements, and then automatisms like picking and clothing, all these things. Then auditory hallucinations, visual hallucinations, and olfactory hallucinations. Bad or unusual smell he may experience, and similar is the case like he hears unusual sounds and sees unusual things, or sputum, whatever it may be. Then third type is focal seizures leading to generalized seizures. So these are focal seizures starting as focal seizures and developing into one of the generalized seizures by spreading to cerebral hemispheres, getting into generalized. The first slide that we have seen, focal and generalized. Focal seizures arising from a focus in the frontal lobe tend to become generalized. Such a seizure may be followed by post-ictal. After the attack, there is a possibility of neurological deficit, then that is known as TOTS paralysis. Okay. Then distinguishing between primarily generalized seizures and focal evolving into generalized seizure is very, very important because the choice of drugs varies between both the two. So simple partial seizures, focal seizures with preservation of consciousness. If there is no consciousness, then complex partial seizures, and focal seizures transiting to bilateral tonic-clonic seizures, that is secondarily generalized. Then the last one, that is infantile spasms, otherwise known as hypsarrhythmia. Probably it is not a form of epilepsy, but there is a possibility of, there is a symptom like intermittent muscle spasm along with progressive mental retardation. And major seizure type in infantile spasms is the epileptic spasm, which consists of a sudden flexion and extension or mix of extension flexion of predominantly proximal and truncal muscles. Okay, the patient will be like this. Limited forms such as grimacing, head nodding, or subtle eye movements also can occur. So the nomenclature developed by the International League Against Epilepsy is considered the standard classification for seizures and epileptic syndromes. So you can have here the main classification. We are not going to discuss about the non-motor involvement because it is just pharmacology class. So motor onset, so automatisms, atonic, clonic, epileptic spasms, myoclonic, tonic, all these. And generalized, same again, myoclonic, atonic, epileptic spasms, motor. Here aware and then impaired consciousness, focal, both the things. And then unknown onset, that is tonic-clonic or epileptic spasms, otherwise known as unclassified seizures. What is this unclassified seizures? It covers undetermined epilepsies and epileptic syndromes such as febrile seizures, wherein young children frequently develop seizures only when there is hyperpyrexia. So it cannot be considered as a seizure or epilepsy. That is unclassified seizure. Then infantile spasms with progressive mental retardation. That's what we have discussed just now. Hypsarrhythmia. It also will not come under the epilepsy. It is unclassified seizure. So these have not yet been classified because of insufficient data or atypical pattern of the seizures. Then status epilepticus. It is a prolonged seizure lasting for more than 5 to 10 minutes or repetitive seizures of any variety without recovery of consciousness between attacks. So that's what we have discussed earlier. So there is no recovery of consciousness between the seizure attacks. When tonic-clonic seizures go into status epilepticus, it can be life-threatening to the patient and it is quite a medical emergency. Then what are proconvulsions? These are all these sorts of epilepsies are because of some pathology in the brain and pathology in the neurotransmitter release. Whereas this proconvulsions means there are some drugs which induce epilepsy or seizures in the patients. So they are known as proconvulsants or epileptogenic drugs. The main mechanism of action of these drugs are by reducing the seizure threshold. So they act as epileptogenic drugs. Examples are withdrawal of alcohol, short-acting barbiturates. Yes, so many A's. Alcohol, not administration, but withdrawal. Anesthetic agents like ether, halothane, ketamine, lignocaine, and analgesics, that is tramadol, pethidine, antimicrobials, antivirals, like penicillin, cephalosporin, imipenem, quinolones, INH, isaclavir, ganciclovir. Then immunomodulators like methotrexate, cyclosporin, tacrolimus. Then sympathomimetic and central stimulants like again amphetamine, ephedrine, aminophylline, darbutalin, cocaine, tricyclic antidepressants, and phenothiazines like antipsychotics and antihistaminics, and even haloperidol, bupropion, lithium, flumazenil. All these come under proconvulsants. Then, what is this endogenous anti-seizure substance? Let us see. Spontaneous arrest of seizure activity after an attack without any drug intervention. One seizure has happened and that seizure gets dissoluted itself. So there is no further second seizure attack, even though you don't put the patient on any drug therapy. Okay. So the brain remains seizure free for some time between the two intervening attacks, that is post-ictal refractory period. So this is mainly because of purine nucleoside, that is adenosine, which is otherwise known as an endogenous anti-seizure substance. How does this adenosine molecule act as endogenous anti-seizure substance? This adenosine molecule inhibits spontaneous firing of cells in virtually all brain areas in the cerebral cortex. So it causes hyperpolarization and exhibits A1 receptor mediated anticonvulsant activity. That is described in case of animals exogenously. Okay. Elevated adenosine levels have been reported immediately after the seizure activity, both in animal models and in patients. So this adenosine is not having preventatory role. After one seizure attack has happened, then there is rise in adenosine level endogenously within the body so that it will stop further seizure attacks. So, but when this endogenous anti-seizure substance is failed, then there is the manifestation of epilepsy. So because it is released post-ictally, it's not tonically active. Even receptor antagonists per se do not have anticonvulsant. Do not have any convulsant activity. Otherwise, okay. So adenosine is having anti-epileptic activity. So means adenosine receptor antagonist must have any convulsant activity, but it is not happening that way because adenosine is released only after the seizure attack. Okay. Adenosine therefore seems to be a wide area in the development of for research of development of newer anti-epileptic drugs. So this is the mechanism of action: A1 receptor activation, seizure suppression, thus giving rise to neuroprotection. Then just few words about the anti-epileptic drugs, the basics. When the cause of a seizure can be determined and corrected, medication may not be necessary. Okay, that is like seizure caused by drug reaction. Seizure caused by fever, that can be corrected immediately. So that cannot be like, that doesn't need like anti-epileptic drugs. Anti-seizure medications or anti-epileptic drugs may be needed only when the primary cause of the seizures cannot be corrected. Most of the times, idiopathic seizures. And then these anti-epileptic drugs are used chronically. Number one, to prevent the occurrence of seizures in people with epilepsy. That is for preventative role. And number two, used in people who do not have epilepsy. That is like to prevent seizures that may occur as part of an acute illness, like in case of meningitis or neurosurgery or traumatic brain injury, all these cases, the patient may land upon in epilepsy. So that can be like prevented. Prevention of epilepsy and prevention of seizures of non-epileptic origin, like for secondary reasons, I can say. And number three is to terminate ongoing seizures such as in status epilepticus, which is a medical emergency. Then coming to the, now let's discuss about the final topic, that is the pharmacokinetics and pharmacodynamics of anti-epileptic drugs. Pharmacokinetics, what are the basic things that we should know about these anti-epileptic drugs in general? Chronic anti-seizure drug administration prevents the occurrence of seizures which can be life-threatening. Therefore, adequate drug exposure must be continuously maintained. However, Many anti-seizure drugs also have narrow therapeutic window. Dosing must therefore avoid excessive toxic exposure. So dose should be balanced, starting with a small dose and then slowly increasing depending upon the clinical improvement of the patient. So an understanding of the pharmacokinetic properties of the drugs is essential for this purpose because of narrow therapeutic window. Then anti-seizure drugs must have reasonable oral bioavailability, must enter the central nervous system. And these drugs are predominantly distributed into the total body water. And some have half-lives longer than 12 hours, like zonisamide and perampanel, which can be administered OD. And for drugs with short half-life, there are preparations of extended release formulations so that the patient will have good compliance. A new anti-seizure drug may increase the concentration of an existing drug by inhibiting its metabolism, and the other way also may happen. So many anti-seizure drugs are metabolized by hepatic enzymes, and some such as carbamazepine, oxcarbazepine, acylcarbazepine acetate, phenobarbital, phenytoin, and primidone. They're all come under like strong inducers of hepatic cytochrome P50 and glucuronide enzymes, uh, inducing the metabolism of other anti-epileptic drugs and also other drugs also that the patient is taking for other comorbid diseases. Some anti-seizure drugs such as phenytoin, diagabine, valproate, diazepam, and perampanel are highly bound to plasma proteins. So these drugs can be displaced from plasma proteins by other protein-bound drugs, resulting in temporary rise in free fraction. So displacement from protein binding. So because of which free fraction of the concerned drug will be raised, and then because of its toxicity will manifest. But in general, systemic clearance also increases along with increase in the free fraction. So it is balanced. So there is no toxicity majority of the times. But for few drugs like phenytoin, we need to be very careful. We need to have like therapeutic drug monitoring also for sometimes to adjust the doses, because otherwise it will give rise to toxicity. Why? That point we'll discuss about when we discuss about the phenytoin. In that session, we'll discuss about it. Other anti-seizure drugs are excreted in the kidney and are less susceptible to drug-to-drug interactions. Some have active metabolites, and extent of conversion to the active forms can be affected by the presence of other drugs. Then plasma clearance is relatively slow. Many anti-seizure drugs are therefore considered to be medium to long-acting. So they can be administered twice or thrice a day. Drug-to-drug interactions. A special issue since the drugs are often used in combination. So we are going for combination therapy. So addition of a new drug may affect the clearance of the current medication such that the dose of the current medication must be modified because clearance is exaggerated. And anti-seizure drugs can also interact with other medications. For example, oral contraceptives, if you give to a patient, a lady, who is on phenytoin, then the phenytoin being an enzyme inducer, it will like enhance the metabolism of oral contraceptive pills so that there is a failure of contraception. So enzyme inducers and inhibitors among anti-epileptic drugs are phenobarbital, primidone, phenytoin, carbamazepine, oxcarbazepine, and felbamate. So this is inducer. And these are inducers, and inhibitors are like valproate, topiramate, oxcarbazepine, and felbamate. So this oxcarbazepine induces CYP3A and inhibits CYP2C19. Felbamate induces CYP3A and inhibits CYP2C19. That is the difference. So this can be asked in your Viva OC, enzyme inducers and enzyme inhibitors among anti-epileptic drugs. Then TDM, that is therapeutic drug monitoring of anti-epileptic drugs. It is the measurement of plasma concentration of any drug in relation to therapeutic or toxic effects. So after seeing the therapeutic effect or toxic effects, you want to go back to the monitor the plasma concentration. That is a therapeutic drug monitoring. It is required for anti-epileptic drugs due to following reasons. Let us see what are those reasons. Number one is there is no simple correlation between the dose and plasma concentration. That is the plasma concentration achieved in different patients with the same dose. Suppose, for example, 100 milligrams of a particular molecule, if you give to two or three patients, The plasma concentration achieved in those patients may be variable. So because of which giving rise to difference in therapeutic effect. But the effective anti-epileptic plasma concentration of many conventional or older drugs is known, whereas plasma concentration of ethosuximide and sodium valproate is poorly correlated with anti-epileptic drug. So the dose and efficacy is variable among the patients. That is one reason for which we need to go for TDM. Then, if adequate responses is not obtained in spite of using the correct dose, where is the problem? Number one is we have to rule out compliance, that the patient is not taking poor compliance, whether the patient is not taking the medication or not, or subtherapeutic concentration is achieved in the body of the patient because of various factors which we have discussed in general pharmacology. Factors modifying drug action. Okay, so that could be the reason. So we need to check it. When there is no adequate response, then better go for TDM for the drugs which have narrow therapeutic index before we raise the dose. Then, for certain drugs such as phenytoin, if dose increment is not according to pharmacokinetic characteristic, the subtherapeutic concentration may directly be converted into toxic concentration. And so the toxic effect with the result that the patient discontinues the drug. That is what I have just mentioned. Suppose, for example, this phenytoin molecule is the molecule which is having narrow therapeutic index. Suppose the patient is not giving good response after you put the patient on phenytoin, and you think that must be because of poor patient compliance or must be because of subtherapeutic concentration. So let me increase the dose. If you go on increasing the dose until you get the therapeutic proper optimum effect, before that, what will happen? It must not be because of subtherapeutic concentration. It must be patient to patient variation also. If you go on increasing the dose, the therapeutic concentration or subtherapeutic concentration may land upon in toxic concentration, which may give rise to various manifestations, various adverse effects, because of which the patient is, if I take this molecule, then I'm getting all these side effects. So better I stop the molecule. So that gives more poor patient compliance. Then number 3, patient compliance can be checked. So that is the first thing that we have to do. Then number 4, helpful in adjusting the initial and subsequent adjustment of doses to minimize dose-related side effects, together with adequate control of epilepsy. So dose-related side effects and dose irrelevant side effects also will be there for each and every molecule. So to balance that, to know about it, we can even think about TDM. If toxicity develops in a patient on multi-drug therapy, the plasma concentration monitoring is helpful in identifying the drug responsible, and so appropriate measures can be taken. So sometimes the monotherapy, the patient may be failing to respond. So then you have to go for combination therapy. Then if you have put the patient on 2 drugs, the manifestations are resulting, then we don't know which drug is responsible for the toxic manifestations. Then we need to go for therapeutic drug monitoring. So check the plasma levels, and whichever plasma level, whose drug's plasma level is enhanced, then reduce the dose. Then the toxic manifestations will be reduced. So this, if toxicity is due to pharmacokinetic drug interaction, monitoring is helpful in adjustment of doses. That's what we just discussed just now. Then the last one is mechanism of action of anti-epileptic drugs. Anti-seizure drugs protect against seizures by interacting with one or more molecular targets in the brain. What are they? Let us see. It's not like one mechanism of action. Ultimate effect of these interactions is to inhibit the local generation of seizure discharges. Number 1 is by reducing the ability of neurons to fire. Action potential stimulation that will be reduced. Initiation of action potential itself will be nullified. And number 2, by reducing neuronal synchronization. We discussed about hypersynchrony. So that is reduced or nullified or prevented. So these are the 2 goals for the mechanism of action of any anti-epileptic drug. So these drugs inhibit the spread of epileptic activity to nearby and distant sites by, number 1 is neurotransmitter mechanisms. Number one, by strengthening the GABA-mediated inhibitory neurotransmission by GABAergic neurons. And number two, reducing glutamate-mediated excitated neurotransmission. That is the means through which a presynaptic neuron depolarizes and excites a postsynaptic neuron. So GABA is enhanced, glutamate is suppressed. So let us see one by one. Mechanisms of drugs used in grand mal and partial seizures. Generalized and partial seizures. What are the mechanisms? Let us see. Number one is inhibition of use-dependent sodium channels. Phenytoin, carbamazepine, valproate, lacosamide, rufinamide, and lamotrigine. All these molecules, they act by blocking the voltage-gated sodium channels that actually remain open due to repetitive neuronal firing. So neuronal firing has started and then sodium channels are open. So these drugs are going to block the sodium channel so that there's further action potential spread will not happen. The higher the frequency of the firing, the greater is the block. They prolong the duration of inactivated phase of voltage-gated sodium channel and delays reversion to the resting phase, otherwise known as membrane stabilizing activity in one way. Inactive state is prolonged and the recovery state is nullified. Okay, this reduces their chances of becoming available again for activation. So there is no more activation of the neuronal fibers. Inhibition of voltage-gated sodium channels ultimately diminishes glutamate release from the glutamatergic neurons. So sodium channel blockade, then further glutamate release suppression. So here you can see sodium channel inhibitors. This is neuronal fiber. Sodium channels are there present. And if we go into the zoom view, so this is open channel where sodium channels are passing through the ion channel. This is inactivated state, the blockade. It is like going to be like this inactivation is going to stay for a long period of time. So the drugs which act through this channel blockade, sodium channel blockade are carbamazepine, phenytoin, topiramate, lamotrigine, valproate, and zonisamide. Okay. And they also allow the slow recovery of the channels. You can see carbamazepine, phenytoin, lamotrigine, valproate, blocking the channels. Then number one is sodium channel blockade. So which will further result into glutamate suppression. And number two, enhancement of GABAergic action. Phenobarbital and benzodiazepines activate GABA receptors to facilitate GABA-mediated opening of chloride channels. So both benzodiazepines and barbiturates, especially phenobarbital. So what is the difference between these two? Is there any specificity of action? Benzodiazepines, they increase the frequency of the opening of chloride channel, whereas phenobarbitons increase the duration of the opening of chloride channel. This is very, very important for both UGs and PGs for VIVOC. Okay. What is the exact mechanism of action of benzodiazepines and phenobarbital in epilepsy management? So that is number one, sodium channel blockade and GABAergic action. And apart from this GABAergic action is of various modes. Vigabatrin molecule, this acts by inhibiting the enzyme GABA transaminase. So GABA metabolism is prevented. So that is one thing. And tiagabine and valproate, they inhibit GABA reuptake. So reuptake is inhibited. So in the synaptic cleft, more amount of GABA is available. That is because of the inhibiting the GABA uptake transmitter. So that is inhibited. Okay. Then so more amount of GABA will be available at the postsynaptic GABA receptors. Then valproic acid, it activates glutamic acid decarboxylase, that is GAD enzyme, and thus increases the synthesis of GABA from glutamic acid. So here you can see vigabatrin elevates GABA levels by irreversibly inhibiting catalyzing enzymes, that is like GABA transaminase. This is blocked. So more amount of GABA will be available. Tiagabine, more this is reuptake is inhibited. So more amount of GABA will be available for the postsynaptic receptors. And then benzodiazepines, barbiturates through ion channels, they act through. So this one is like by increasing the frequency of opening of chloride ion channels, and barbiturates by increasing the duration. So that is like number 1, sodium channel blockade, number 2, GABA, and number 3, blockade of NMDA or AMDA receptors. So activation of NMDA and AMPA receptors by glutamate produces depolarizing responses and initiates seizure activity. It is excitatory. So here the felbamate blocks the NMDA receptors, whereas rufinamide inhibits metabotropic glutamate subtype 5 receptor. And phenobarbital, topiramate, lamotrigine, and perampanel, they block AMPA receptors, and valproate inhibits glutamate synthesis. Okay. So sodium channel blockade, GABAergic activity, and glutamatergic activity suppression through NMPA, AMPA, and NMDA receptors. And number 4 is, apart from sodium channels, N-type calcium channels are also involved, which are getting blocked with lamotrigine and gabapentin. Because of N-type sodium calcium channels are also blocked, so there is decreased release of glutamate in the synapse. And apart from this, another mechanism, peculiar mechanism is there, that is selective binding to synaptic vesicular protein. So the main molecule which acts through this mechanism is levetiracetam, which binds to this synaptic vesicular protein of synaptic vesicles in glutamatergic and GABAergic neurons. And then they decrease the release of glutamate and increase the release of GABA. That is like modulation they can do. Okay. Then by blocking the effects of neurotrophic factors, that is lacosamide inhibits collapse response mediator protein. This protein is involved in the production and release of brain-derived neurotrophic factors and other neurotrophins. So they play an important role in epileptogenesis by provoking membrane excitability and by promoting synaptic plasticity. So that is blocked. Okay. Then you can see here, this is the felbamate acting through NMDA receptors, perampanel acting through AMPA receptor blockade. Then this is like gabapentin, pregabalin acting through calcium channel blockade, and egozabin through potassium channels. And all these drugs act through voltage-gated sodium channel. Phenytoin, carbamazepine, lamotrigine, lacosamide, zonisamide, and oxcarbazepine. And levetiracetam binding through the synaptic vesicular protein for neuroprotection. Then that is for generalized seizures, mechanism of action of anti-epileptic drugs. Okay, sodium channels involvement, calcium channel involvement, enhance GABA and decrease glutamate and synaptic vesicular protein. All these mechanisms will be there. Then mechanism of drugs used in petit mal epilepsy are absence seizures. Inhibition of T-type calcium channels. There it is N-type calcium channels. Here it is T-type calcium channels. Remember, this is like petit mal. T letter is there in petit mal. So T-type calcium channels. You can remember that way. Then here petit mal, E letter is there. So the drug molecule that is used here is ethosuximide. Okay. So this ethosuximide inhibits the low threshold calcium currents carried by T-type calcium channels. Okay. There it was N-type calcium channels. So T-type calcium channels currents are responsible for generating the thalamic cortical pacemaker currents, which will go on spreading petit mal attack. Inhibition or reduction of this low threshold T-type calcium channels also accounts for the anti-seizure activity of valproic acid also. So both the molecules are used for the management of absence seizures. So this is calcium channel, T-type calcium channel blockade, that is like valproate and ethosuximide. You can see. Calcium channel blocker prevents the release of internal calcium stores. Cells do not respond to it. Then action on ion channels. So we have discussed about sodium channels and calcium channels. Just like a recap, drugs acting through blockade of sodium channels, phenytoin, carbamazepine, lamotrigine, and topiramate, and valproate, zonisamide, and calcium channel blockade, ethosuximide, valproic acid, and zonisamide, and enhancing GABA receptors. So directly ion channels action, benzodiazepines and phenobarbital, release of GABA, that is by gabapentin, inhibiting GABA amylase, valproic acid and vigabatrin, inhibiting uptake, take T for tiagabin. Inhibiting excitatory amino acid, that is like the glutamatergic transmission, decreasing the release, lamotrigine, fulvamate, topiramate, and phenobarbital, and miscellaneous levetiracetam and acetazolamide. So drugs which block the voltage-dependent sodium or calcium channels, all these drugs, so they are used in generalized tonic-clonic and even partial seizures. And then here, T-type calcium channels also, generalized tonic-clonic seizures and partial seizures. And drugs which suppress excitatory amino acids, these drugs in generalized tonic-clonic seizures. Then drugs enhancing inhibitory events, that is like exaggerating GABA mediated action. All these drugs are used in all types of seizures. And drugs which block only T-type calcium channels, that is ethosuximide, used in absence seizures. So here you can see the same mechanisms. So all these drugs, sodium channel blockade, levetiracetam combining with the synaptic vesicular protein, reticabin acting through potassium channel, and perampanel AMPA receptor blockade, and ethosuximide T-type calcium channel blockade, benzodiazepines and barbiturates we have discussed already, ion channel direct blockade, and then tiagabin inhibiting the reuptake, gabapentin and pregabalin calcium channel blockade. This is again reticabin also acts through potassium channels. Okay, this is the ultimate overall effect of anti-epileptic drugs. Here you can see the same thing, sodium channel blockade, potassium channel involvement here with the potassium channel activation, reticabin, then antagonism of glutamate, these molecules, GABA activity, postsynaptic neuron. So then GABA reuptake inhibitors, then SV synaptic vesicular protein, levetiracetam, calcium channel blockade, ethosuximide, and all these things, and alpha-2 delta modulation, gabapentin and pregabalin. That is through calcium channel blockade. Sodium channel blockade, calcium channel blockade, and then potassium channel activation. These are the three channels that are involved. The neurotransmitters, GABA and glutamate. So this is the final diagram. Thank you. Thank you, one and all. So this is about the introduction to anti-epileptic drugs. If you have any doubts, then you can get back to me. So we'll discuss next time about the second session, that is the conventional anti-epileptic drugs. Sorry for the delay because I was having like continuous PG exams and UG exams and constant exposure to the screen, laptop screen. So I was having a migraine problem. So that is the reason why I delayed in my presentations. Okay. Thank you. Thank you, one and all.